Hej och välkomna. Vi ser att det droppar in folk. Vi har precis öppnat webbinariet så vi väntar någon minut på att alla ska hitta in och lyckas ta sig över Zoom. Hi everyone, we see that attendees are coming along. We will wait another minute or two until everyone has managed to come inside this Zoom room. Okay, I can see that the pace of entrances has gone down a bit. Very welcome to this webinar today, the Swedish Choice Reform and Equity. My name is Anna Sakadi. I'm a professor of social medicine at Uppsala University. I'm also the chair of the Swedish Association of Social Medicine and Public Health. And we are extremely pleased to have this seminar, and I will very shortly be giving it over to the wonderful collators of this seminar. But before I do, I would just like to say a couple of words about us and our case. We are an association that is 130 persons strong, but you wouldn't know that because our presence in the general debate is by far further than what you would think is a consequence of our numbers. So we might be small, but we are like the ants. We're very strong and we get things done. And one of the things we do is this webinar series, which has been extremely successful, and we're so very pleased. We did start before the pandemic, but it really became routine during the pandemic. And we also always hang a debate article on these webinars. Now, I often get asked the question if you have to be a socialist or very political, like party political, if you're dealing with social medicine. And I always say that no, we don't deal in political parties. But if you believe that society and the way we organize society and healthcare has consequences for people's health and well-being, well, I guess that's, in a sense, that's a political kind of statement. So we can never quite get away from politics, but we always stay away from political parties and those kinds of things, unless we get invited to discuss on a scientific basis. So without further ado, I would just like to hand over to Professor Margareta Kristensson and the rest of the organizing committee, and welcome you all and wish you a pleasant, interesting, and stimulating webinar. Thank you.
Thank you so much, Anna, for this wonderful introduction. And again, warm welcome to this webinar about the Swedish Choice Reform and Health Equity, which is organized together by the Swedish Society for Social Medicine and Swedish Society for Medicine. My name is Helena Frilingsdorf. I'm a psychiatrist and a resident of social medicine. And I'm also the chair of the Swedish Society of Medicine's Committee for Global Health. And I will moderate this webinar together with Margareta Kristensson.
I am a professor emerita in social and preventive medicine and chief physician as such in Region Östergötland and Linköping. And I also want to add to what Anna said, that this is not about politics, but it is about policy and how policy has effects on people. And I just wanted to start by don't know why it doesn't work. By the Swedish law on health and the Swedish health and disease law. We have a complicated name, men alla svenskar vet vad det är. And the portal paragraph says that the aim for health services is a good health on equal terms for the population, and that this can be given for with respect for equal value for everybody and for people's dignity. And the last one, those who have the greatest need shall come first. So it should be based on the need of health service and nothing else. And what we do see in Sweden is that while this is our aim, my machine doesn't work. I don't know why. Yeah, we see a dramatic development of health divide in Sweden over the years. I grew up, and I think many still have that picture that Sweden is an equal country. We have the best equity in the world, and it has always been like that, and it stays like that. But as you can see, there has been a dramatic development of during the last decades, where inequities in health are rising, and it's a graded rise. So it's not only dependent on the poorest. And the same picture will be if you, instead of education, which is easiest to assess, have income. So dependent on people's life conditions, we have increasing inequalities in health. So today it's instead of a 2-year difference between those who have and have not, it's a 6 or soon 8 years difference. And while I sometimes find that it is not on the political agenda as much as I had wanted to, when you hear the leaders of the political parties on the TV, they do not discuss this. But other people find it very remarkable. And they talk about the welfare paradox, with the persistence of socioeconomic inequalities in health, even in the highly developed welfare states of Western Europe. And that this is one of the greatest disappointments of public health. Health inequalities have not only persisted, they have even widened. And this is John Mackenbach, one of the best. For this sake, actually, our present government set aside a Swedish Commission for Equity in Health a number of years ago, and 2014. And the report ended up in a proposition in June 18 that we are to the politicians decided, all of the parties, to create societal prerequisites for a good and equal health in the population and close the amenable health clefts within one generation. One generation is 30 years, and this is 3 years ago, so 10% of the time has already passed. And in the areas which we talk about here, you have a number 8, which before was named Health Promoting Health Service, but now is called an Equal and Health Promoting Health Service. And how is this, Helena? Or do we have this? What do you think?
Well, I would like to start by presenting some old research. This is called the Inverse Care Law, which was published in 1971 by Julian Tudor Hart. And his line of research looked at whether market forces are compatible with health equity. And this is a very distinct summary, so I will read it. The availability of good medical care tends to vary inversely with the need for it in the population served. And this inverse care law operates more completely where medical care is most exposed to market forces. and less so where such exposure is reduced. The market distribution of medical care is a primitive and historically outdated social form, and any return to it would further exaggerate the maldistribution of medical resources. So this was published, as I mentioned, in 1971. And in the 90s, the Swedish politicians chose to expose Swedish healthcare system to quite heavy market forces. And in the meantime, since the 90s, we have seen, as Margareta already showed you, how the gap in health inequity has widened. So next slide. So the question that we would like to answer or try to answer with this webinar, and perhaps we may need more webinars, and this question is probably multifactorial, but the main question is, has the Swedish Choice reform contributed to the rising inequities in health in Sweden? And to find out, we have invited a line of distinguished speakers who have different perspectives on this issue. And as you can see, each speaker has 20 minutes. There will be 5 minutes for questions and answers in the end of each presentation. So if you have any questions for clarifications or any specific questions to any of the speakers, feel free to write your questions directly in the question and answer function in the chat. We will also have a plenary discussion for 25 minutes at the end of the webinar. So now it's my pleasure to introduce our first speaker, Göran Stiernstedt, who is an associate professor at the Karolinska Institute and investigator at the Ministry of Social Affairs and Health in Sweden. Welcome, Göran.
Thank you very much, Helena. Now I will start with trying to share the screen. You can see that now? Very good. It's always a bit nervous when in this digital presentations. A good start there. Thank you very much for inviting me to speak on this matter. The reason probably is that I led an investigation from the Swedish government trying to evaluate this care choice reform. Actually, the name of the investigation was Governance Towards Equity in Care. But when we published the report in 2019, as you could see in this, we published it as digiphysical choice of care. And the reason for this was that very much was about the so-called internet doctors who had been at a separate system actually. But a little bit more of that later. We also published first a separate report where we could see that actually it's no sensational, it was well known since earlier that lower income and lower educational level relates to higher consumption of care. Weak socioeconomy related also to better continuity. Actually, lower income and lower, it was more common among this population that they could give the name of their nurse or their doctor. But the problem was that weak socioeconomy also relates to less participation, for example, in screening programs, and also refrain of care because of economic reasons. We also found that when talking about economy, what is the cost of care for each, in average for each patient within different ages? You could see that in the beginning and in the end of life, actually higher income relates to more costs, but in between, lower income and lower integration has higher costs. As Margareta already has told us, we have a law in Swedish healthcare, HSL, hälso- och sjukvårdslagen. And also you mentioned the goal is good health, equal care, and the need of care is the base of prioritization. But regarding the choice of care, we also have some other laws too. And for example, the patient's right to choose their provider in outpatient care. You could choose your provider actually in the whole of Sweden. That's within the patient law. But when we talk about this mandatory care choice, vårdval in Sweden, that's a law of procurement. As another law, well-known law of procurement is lagen om offentlig upphandling, procurement law of the law of procurement in public sector actually. This is all often mixed up actually. Many times when I met healthcare personnel and discussing the organization and the vårdval, for example, I could tell you that I think there are a lot of problems with doing the vårdval. Oh, you are against the right to choose. No, I'm not against the right. I'm in favor of the right to choose. But what I discuss is the vårdval and its effects in the system, the separate law that you have the mandatory care of choice for the county councils. What I will present to you is the effects of vårdval on equity. And I will just not to mix it up, I'll use actually the Swedish word vårdval. This was introduced more than 10 years ago, and what the law said that each county council puts up criteria for authorization as provider of primary care, and it also includes the rules for reimbursement. And the county council can't deny providers that fulfill this criteria the fri etableringsrätt in Sweden is the free right of establishment. And when introduced, it was very much focused, and the leading word was quality competition. I think the politicians meant that the inhabitants should choose their provider according to those producing good quality. And by competition, those producing not so good quality should not be on the market, actually. There was, at this time, very much focus on new public management. There was also very much focus on competition neutrality, because I think that many politicians, that actually those governing Sweden, they thought that there was a risk that councils may favor their own providers, those owned by the county council, by private providers might get less favorable conditions. And often used word was leave it to the market, and I think that you could summarize that was a little bit naive, which is my opinion, that Sweden is a little bit naive when introducing market solutions actually in the public sector. You could compare with the school reforms, for example. And the first thing you could mention regarding equity is what we get from this law and what we still have. It's not a system. It's 21 different systems because we have 21 county councils. and you should not study this in detail. It only tells you that there are not two county councils that have the same conditions and the same systems and the same rules for economic compensations, for example. And we try to evaluate this reform after 10 years then, vårdval after 10 years. The first thing to comment is that the unlimited right to choose and unlimited right of establishment, it was rather unique for Sweden. When evaluated the goals of the reform, there was one goal was certainly to improve the right to choose, and we found that it has improved. Another goal was to increase the number of providers, and we found that the number of providers had increased, especially in the beginning, the first years. Then it was rather stabilized. Access hadn't improved, this was another goal. Quality coefficient was extremely difficult to evaluate. And equity has certainly not improved. We didn't say that it had worsened though. Continuity was still weak, and the efficiency was low. And the resources hadn't increased, actually they had decreased, because the number of providers had increased and the resources had not increased. And also vårdval was introduced in the system with the low capacity. Sweden was a relatively small part of the healthcare expenditures on primary healthcare, which has made more difficult to choose, more difficult to plan, more difficult to handle the working conditions for personnel. And the governing towards both demands and need creates tensions. The vårdvalet stimulated demand and mobility, while the county councils tried to govern toward the hälso- och sjukvårdslag, HSL, which is more about continuity and so on. And there was a tension, those different goals didn't match actually. And there was a very limited national governance. But there were also differences between county councils regarding, for example, establishment in socioeconomic weak areas, which has been very much discussed actually. This was not a scientific investigation, but because we didn't have enough data on that, but we did really had a vision that there were differences between county councils, and those were related to the reimbursement system. How county councils reimbursed according to care need and paid extra, for example, according to geography, really stimulated, could stimulate and resulted in more establishments in socioeconomic weak areas. What could you do with the system? Because of course you could change it dramatically by just finishing this law, for example. But within the system, what could you do? Yes, I would suggestion was you must orientate to more patient-oriented based and continuity and easy access. We need more of a national system, for example, more standardized reimbursement on a national level. And we also suggested actually that there would be the same patient fee Sweden, and why not have the patient fee 0 to stimulate actually and also improve access for those with weak economic conditions. And the digital care also it should be integrated. It should not be a separate system. The internet doctor as a separate system did really not improve equity, and also cost a lot of money. It's a tool to use the digital care. It's not a separate system. And about this, because very much it's about reimbursement, and if you how you design the system. I think it's really clear that the dream of the perfect system, it existed for a long time, especially among our politicians. But today, no one talks about it because there is no perfect system. But money talks, and it's easy to predict the effects, how you put money in the system. And the best way to use it, and the least bad, is capitation, paid according to the patient you have on the list. And the capitation should be based on the care need. The advantage of using, for example, care need index is also that the indicators are more stable over time. For example, related to income or education level on the populations. Avoid too many variables, indicators, put only small or no part at all on production or productivity. But there is always within every system so-called cherry picking, trying to catch the most, the patients patients most favorable from an economic point of view for the producer. What we recommended was much better follow-up actually, because we do need a system that is more based on follow-up, they're more based on professional follow-up, and this follow-up should be in a dialogue actually, and also comparisons with other producers, for example. And just one thing that could, as we saw examples of, you couldn't have a system that young healthy patients is the most profitable patients, for example. But we also saw a good example who county councils who could handle this. And I think the last advice regarding equity is actually to, as I said before, to focus more on those follow-up. But the advice regarding improved equity, what could you do to improve equity in Swedish healthcare? In my opinion, the most important is the transitions towards a system where primary care is much stronger than it is in Sweden today, and it needs more resources, because that favors equity. It favors care for those who is not that strong within the society. Thank you very much.
Thank you so much, Göran. We do have 2 minutes left. I see no questions out there. You may raise your hands. Waiting for this, I couldn't help because the two of us spent many years working on national quality registers. And we also talked about patient-reported outcomes as part of these. I hear you beautifully describe that more continuous follow-up and learning and feedback to the professionals would be the best way of working. And we do have the system, so why don't we use it?
Yes, I wondered that too. Mm-hmm. I think one thing is that the professionals, for example, they must meet other professionals. Mm-hmm. But when we have handed over the follow-up to other mm-hmm. and really than healthcare professionals.
So they need to get the results back themselves.
Yes, and you also, I think it must be regarding, you could not, has been too much put on papers. You must discuss this between four eyes actually, because for example, not making very well on an indicator, it may relate to the population you have within your area, for example.
Absolutely.
And to understand that, you really need a dialogue between four eyes to be more than but I think you understand what I mean.
Yeah, absolutely. So professional dialogues on the outcomes and actually for learning and professional development and pride, and within a non-money driven.
Exactly, because the proudness, the professional proudness, is that you should produce good quality.
Yeah,
but
exactly.
you always have the side effects of cherry picking, as I said. You take the most favorable paper. But if you could see that your vårdcentral is, why do you have those patients and not those patients? But your neighbor has it. I think that will have you really, that gets right into your heart actually, and the chance of that you change your behavior is much greater.
We shall come back to you, Göran, in the plenary, and we go on now. And thank you so much for this. And now it's my turn to introduce to you the next speaker, and she comes from a very beautiful city called Linköping. Where Therese is a PhD student in health economy, and on actually the subject we are talking about here. So at the Center of Medical Technology Assessment and the Unit of Healthcare Analysis. And Therese shall speak on free care choices effects on equity in specialist care for elective spine surgery. So we leave primary care and go to spine surgery. Welcome, Therese.
Thank you.
Just to everybody, do put your questions in the chat. Otherwise, Helena and I take all questions, and that's not fair. So you must write them down. So, Therese, welcome.
Thank you very much. I will start sharing my presentation here. So can you see my presentation? Yes. So yes, thank you for having me. I'm really excited to be here today because I find this subject really, really interesting. And as Margareta said, I will talk about specialist care and more specifically elective spine surgery. And elective spine surgery in Region Stockholm in 2013, the private healthcare providers went from being accredited through Public Procurement Act to being accredited through the Freedom of Choice Act, and I will call it patient choice just to make it easier, even though it's quite difficult to say patient choice in English for some reason. So as Göran also mentioned, that means not only that the patient can choose, but there are differences for the providers as well. So first of all, they go from this recurring procurement process where they risk kind of every time losing their right to practice or their accreditation to this continuous commissioning contract instead with a set price. So that means that there are no longer any restrictions regarding the volume, so they can produce as much care as they wish in a way. But the regional authority, in this case Region Stockholm, they decide how and what they pay for. So that is actually a very important aspect, how they pay for the services the providers give. So the structure of the reimbursement program and the commissioning contract is very important. And I also think it's very important to involve the different healthcare professions that are affected by this commissioning contract. And in this case, the spine surgeons were involved in designing both the contract and the reimbursement program. So I will also describe shortly the reimbursement program within elective spine surgery, because it combines a bundled payment with performance-based payment. So at the time where the healthcare provider register the surgery, they receive a prospective payment from Region Stockholm, which includes a bundled payment. And that bundled payment, so let's see if I can get this pointer, should cover all future healthcare consumption for a year after the surgery. So if a patient that undergoes surgery afterwards experience complications, or if they go to a physiotherapist for rehabilitation, the spine surgery clinic that performed the surgery needs to pay for these visits, even if it's an external healthcare provider. So that means that the initial healthcare provider will receive these invoices from Region Stockholm and pay for it themselves. So it's only one payment at the beginning of the year, which also include the expected performance-based payment, which I will come back to. But to promote a need-based healthcare is also adjusted for patient characteristics. So a patient that has a higher comorbidity level, for example, would probably require more care, post-discharge care. So they will receive more money for patients with higher comorbidity, for example. And to avoid that healthcare providers stint on necessary care during this care episode, they also receive an adjustment of the performance-based payment 1 year after surgery. So that means if the patient improved more than what was expected, they will receive a bonus. And if the patient improved less than expected, the healthcare provider needs to repay money to Region Stockholm. And the performance-based payment is based on global assessment, which is a measurement that is registered in the National Quality Register, Swespine. And that is a question of how is your back or leg pain today compared to before the surgery. And then as you can see, they have these different alternatives that they can choose between. So that is the reimbursement program. And me and my colleagues at Linköping University, we evaluated the introduction of this patient choice in elective spine surgery. And we used patient-level data between 2006 and 2016. But we also conducted 49 interviews with representatives from both healthcare providers, but also Region Stockholm, to get a fuller perspective on what happened during this time. So what did we find? And as I mentioned, with patient choice, there's no restriction on volume. So one hypothesis could be that the volume will increase. And that's exactly what happened. As you can see, patient choice was introduced in 2013. And 2 years afterwards, more patients were treated compared to before, even though there's a big increase even before. But what does this say about equity? And it is difficult to say anything about equity from this. But in a way, one approach can be that is this increase, does that equally reflect the case mix previously treated, or has it increased patients that are more favorable to perform surgery on? So to investigate this, we performed, first of all, a logistic regression analysis to see whether there were different socioeconomic factors affecting the outcome of surgery. And in line with other studies that also found that socioeconomic factors actually affect the outcome of the surgery, we found that age, low educational level, and being born outside of Europe had a decreased odds of a successful surgery. So that means that these patients that are older, have low educational level, and born outside of Europe actually has a lower odds of a successful surgery. Whereas patients that have middle or high income level actually have higher odds of experiencing a successful surgery. So the next question would be whether these patients with these risk factors, or what to call it, were treated to a lower degree after the introduction of patient choice. And so we performed another logistic regression analysis. And as you can see, that did not seem to be the case. So this is the odds ratio for being surgically treated after the introduction of patient choice. So we compare the patient group after the introduction with the patient group before the introduction. And with a higher comorbidity level, you had a higher odds ratio of being surgically treated after the introduction, as well as patients that were born outside of Europe. They also had a higher odds ratio. But patients that had a middle or high income level, they were treated, they had a lower odds ratio of being treated. So we could not seem to find any effects of cherry picking with this approach. And I should also say that this was only during the first 2 years. And according to the interviews, the healthcare providers were really busy of just learning about the new commissioning contract and adapting their practices. So maybe this could consider as more of a phase where they were adapting, and we need to investigate this further in the long term, in the future. We also looked at different patient-reported outcome measures to see whether people had a higher or lower quality of life, for example, before surgery, but we found no differences when we looked at EQ5D, or we didn't find any differences either when we looked at Oswestry Disability Index or global assessment, as I mentioned in the beginning. And global assessment was the measurement that was used for the performance-based payment. So that was one part of it, but I also think it's important to look at under what conditions do the healthcare providers provide care? Do they have the right prerequisites to promote equity? And so we asked about their thoughts about the Freedom of Choice Act, the patient choice. And they said that with patient choice, they got more freedom. As one said, because of patient choice, we got more freedom to be able to decide ourselves what we think will be the best for the patient. And this was also like they were able to make long-term plans. They didn't have to worry about next procurement process with all the resources they had to invest in that process. So now they could focus on just how can we perform the best care possible and what can we do to make our patients better. And others also said that patient choice avoid unserious low bidding actors that are not really in it to make care better, but just make it profitable. And as one person said, I've been involved in quite a few procurements, and in the end, it's only the price that matters. And there are many actors who are not serious, who don't treat the more difficult patients and put in really low bids during the procurement process. A serious clinic can't practice under those circumstances. And it's also less uncertainty, as I mentioned. So as someone said, the first thing I thought was, thank goodness we won't need to go through this procurement process again. So it was a big relief for these private healthcare providers that it was patient choice instead of this standard procurement process. And what did they think about the reimbursement? So they said that because of these invoices of post-discharge care, they received a more comprehensive picture of their patients. They didn't only see the surgical procedure, but the full healthcare episode. So it actually drives private healthcare providers to take responsibility, not just under the knife, but that you actually own the process for a while longer. And what I think is the difference when I look at other areas of patient choice is that we have a more complete picture of the patient. But a problem was the insufficient IT systems. They didn't hindered collaboration with other healthcare providers, and it also increased the administrative burden. So they had to spend more time auditing manually because the IT systems didn't support the controls they needed. And the lack of transparency in how this performance-based payment was calculated also made it too difficult to understand how they can affect it. So they agreed with the idea of this performance-based payment and thought it was really good with this quality aspect in the reimbursement program, but thought it was too complex to spend time on trying to understand. So that didn't really work out as planned. So the conclusions of this case is that so far we were not able to see any shifts in case mix or any signs of cherry picking. And we couldn't see any effects on PROM before and after the surgery or introduction of patient choice. There was still the same effect of the surgery, so there's still an effect of surgery. But with patient choice, it decreased uncertainty and healthcare providers were able to make long-term plans. And it's important to think about how these financial incentives actually can be used to promote a holistic perspective, that healthcare providers were informed about the needs of their patients after surgery as well, because that made them realize that, okay, we need to do things now to improve things in the future, to avoid things in the future, for example. And a holistic healthcare that promotes equity requires continuous communication between regional authorities and healthcare providers. And this is very evident in the interviews that there was a lot of frustration that the lack of communication with the region Stockholm, because they were always so busy with other patient choices. So there was this frustration, and I think it's really important to revise commissioning contracts when you find problems. So good communication is essential here. Thank you. That was quick, or not quick maybe, but I talked fast.
Exactly, on the second, perfect. So thank you so much, Therese, for this very interesting session, and the floor is open. Who wants to start?
I don't see any questions in the chat function, so I thought I would take the opportunity to just ask, or first, thank you so much for sharing your research and this interesting perspective. And I was curious if you could elaborate a bit more about what these providers are doing to decrease the unequal. I mean, even if it's not because of the choice reform, what they're doing to decrease the unequal health outcomes after surgery.
Yes, and like this is a problem within elective spine surgery, that it is difficult to tell which patient will actually benefit from the surgery. That it could be one patient that don't have any risk factors at all, that don't improve as expected after the surgery. And there could be this risk patient that improves a lot after surgery. So that is a problem. And I think in a way this, with this new commissioning contract with the reimbursement program, it gets even more clear that they need to find out what they can do to improve patient, because they do gain financially of making, since the performance-based payment is based on the expected result. And if you have a patient that is not expected to improve much, they will receive a bonus that if they are able to improve it more than expected. So I think it is, so it brings back the question of how to finance research and education with private healthcare providers. And I think that is a difficult question, but I think it needs to be resolved since it's so much volume being produced by private healthcare providers. It's important to understand that they perform a lot of important research as well that can be used to better know what patients that should be surgically treated. Yeah, sorry, a long answer.
If I may, Helena, can I have a question?
Sure, I just wanted to follow up if, like not just in choosing the patient, but maybe, because it sounds like then that it could be meaningful to allocate more resources to high-risk patients in terms of rehabilitation and the aftermath after the surgery.
Yeah, so they also, for example, some realize we need to have some like physiotherapy before surgery to increase the chance of better improvement after surgery, for example. So that is an example of what some are trying to do. Yeah.
Thank you, and over to you, Margareta.
Maybe only briefly. I'm thinking about the positive expressions from the clinicians, was that really about the free care choice, or was it that they had a reimbursement system which gave them a whole package payment? So they had a payment for the whole period, and thereby a possibility to plan, which they could have had also in an ordinary system.
Yeah, I think the most important aspect of the free care reform or free choice reform was that they didn't have to go through this recurring procurement process where they have to place bids on how much they were willing to accept how low price they were willing to accept to perform surgeries. So I think that was the most important part, that it was a continuous contract and everyone has the same, it's a set price no matter healthcare provider. So yeah, I think that was the most important aspect of Freedom of Choice Act compared to Procurement Act.
So not really about freedom of choice, but rather a different reimbursement system.
Yes, except from that they don't risk losing their accreditation every 5 years. They are in charge of their own practice, but they also appreciate it. Like, yes, they appreciate knowing the price. Yeah. And so that was and all the information they received also about their patient, that was a very important aspect for them.
Thank you. We come back in the plenary discussion, and again to the all you out there, put your questions on there, otherwise Helena and I take all the time. That's not the meaning. Thank you again, Teresa. And with this, I leave the word to Helena to present the final speaker before the break.
Thank you. And I'm delighted to introduce Bo Burström, who is a professor of social medicine at the Karolinska Institute, Stockholm. Welcome.
Thank you. I'll see if I can share my slides. Okay. Does it show?
Yes.
Here it comes, yes. The title of my presentation is Equity Impact of the Primary Healthcare Choice Reform in Sweden. And this is based to a large extent on a scoping review that we did on the impact of primary healthcare choice reform. Now, I can benefit from the previous speakers, both Margareta and Göran have sort of laid the ground for what I'll be talking about. But just to remind us, primary care is an important part of the healthcare system with comprehensive responsibility for prevention, treatment, and rehabilitation of patients. Also responsible for referral to secondary care, with responsibility it should have for population health, and with cooperation with Social Security Office, elder care, municipal social services, and so on. And there are many different models with different characteristics, but this is what we would expect primary care to do. Now,
sorry, just a sec. I'm sorry to interrupt you. Do you think you could put it on visningsläge?
I thought I did. Let's see.
Yes, I know. You can't see what we see. That's why.
Right. Let's see. Duplicate. No, växla mellan.
Yeah, I think you should take the växla mellan föredragsvy och bildspel.
Okay, let me see. I did something wrong now.
Yeah,
perfect.
There you go.
Now it works. That's better. Okay, so the choice reform, Göran said all the legal details, which are very important, I think. But the reform was presented very much as a choice reform, but it was very much driven by the free establishment of clinics by private providers. And it resulted in almost 300 new providers. Now, these could have wider or more restricted assignments, including also other types of outpatient care. Now, the implications of the reform basically is that money follows the patient. And that means, on the other hand, that there is less opportunity for need-based resource allocation by politicians. It used to be the case that politicians could put more resources in areas, for instance, where the needs were greater, but this type of arrangement didn't enable that to happen. It also meant that you had an individual listing of patients, which meant, you could be listed, you can live in the suburbs and be listed in the central city. So there was no responsibility for population-oriented health promotion, which I think is a very important part of the mission of primary health care. The rationale for doing this was to increase access to primary care. And as Göran said, one of the major problems in Swedish healthcare is the low resourcing of primary care in Sweden compared to other countries. I think compared to the UK, we have a bit more than half of what they put into primary care is done so in Sweden. So that was a good intention to increase the access, but it was also very much to introduce market mechanisms and in order to put more emphasis on increasing efficiency in healthcare, the thought being that multiple providers and market mechanisms and competition would solve this issue. It's also part very much of the kind of consumer-driven notion that we can see also in terms of choice of schools. The free school reform is very much a parallel to this. It happened the year before this was legislated in 2009. There was a similar reform in social care, opening up for private providers of, for instance, elder care and nursing homes. And underlying this was that freedom of choice could be regarded as a goal in itself. Now, you could ask yourself, choice for whom? Patients should choose, but in effect, providers set the scene for choice by their location of clinics. If you don't have a clinic nearby, you can't choose a clinic nearby. Now, and it turns out that few providers have established in disadvantaged areas, again, because of difficulties doing business there, basically. There are greater obstacles for some groups to travel to other providers, which makes their choice opportunities less, as for people who live outside cities in rural areas. Now, I've listed a number of articles that discuss this. There's a group in Uppsala led by Ulrika Wimblad who have studied extensively this issue, both when it comes to the geographic equity of establishment and of how rural healthcare can operate with this, and also the risk selection, which patients are listed at different types of centers. We should remember also, I think both Göran and not least the previous speaker talked a lot about the impact of reimbursement systems, because this reform was followed by changes in reimbursement systems. And it's really important to consider both at the same time if you look at the impact of reform. Now, as Göran said, reimbursement systems usually come as capitation, which is the annual listing fee, or then some of it might be based on fee for service, payment per visit, or you can have this payment pay for performance, related to the objectives that commissioners want you to reach. Now, the capitation may also be need-weighted or not. And as Göran said, Care need index is one approach of doing that. Another one is what is called ACG, adjusted clinical groups, which is based on diagnoses that are registered. It used to be further back that primary care funding was of kind of direct funding, anslagsfinansiering, but then it was changed to revenue funding, which is intäktsfinansiering. So this meant that doctors had to become businessmen in some respect, think of how they could make ends meet with their clinic and the listed patients. There was an intention also to create equal conditions for providers, which was expressed as having the same reimbursement system for all providers. Now, I think that's where we go wrong. If we think that you can have equal conditions, if we want equity in health and in healthcare, we need to have unequal reimbursement to get there. We did, this is just to show some examples of papers where we have done this more thoroughly, looking at, this was a scoping review looking at what studies had been done a few years into the choice reform in Sweden. We did another one, the first one was by a PhD student who looked at the impact on number of visits. Second one was the scoping review. And we just recently had a study looking at the impact of reimbursement systems, a qualitative interview study with providers, how they perceive payment initiatives. Now, the location of providers is very skewed across Sweden. You can see the blue part, Stockholm is an outlier here with having almost 70% of private primary care providers, whereas the north of Sweden and more rural areas, they have much less. And it's basically when the National Audit Office looked at and did a review of the choice reform, they noted that this is a reform that has actually benefited more of the well-to-do areas in larger cities. That's where the access to care has increased. And in rural areas, it has in some instances operated the reverse, so that it has drained some places of resources. Now, you've already talked about the inverse care law, and I think the choice reform really serves as a perfect example of how that has operated in Sweden. Now, turning outside Sweden, if we look at other countries who were further ahead in this choice reform idea than Sweden, there was a review of studies done mainly from the United Kingdom, but also from other European countries, looking at what are the common findings of choice reforms in different countries and what are the implications for equity. Basically, choice is not, as you might expect, a high priority among patients. That was how it was presented when it was launched politically, that this is something that patients want. But actually, it was more the politicians that wanted to open the floor for the choice reform in Sweden. There's also a study by Mio Fredriksson, political scientist in Uppsala, who looked at the political decision-making process around this in Sweden. Now, a common finding is also that better educated people are more likely to make use of choice because of the differential access to information. Choice tends to increase the cost, which Göran pointed out it hasn't done in Sweden, but in general terms, you need to have a greater supply in order to get this choice working. There's no evidence for improved quality or outcomes, but there's a huge risk of fragmentization of care for persons with complex health problems. And in one of Göran's previous government investigations, this was pointed out in Sweden as well. And at the end, it increases inequalities. Now, if we think of factors affecting healthcare utilization, we know that geographic proximity to facilities tend to increase consumption. And then we have the other side, which is demand for health services, which differs between groups. And men and women seek care differently, but so do different socioeconomic groups. Part of it having to do with the degree of health literacy, how much you know about what keeps you healthy and so on, and where should you seek care. But it's also affected by things like patient fees, how you're received by staff, cultural factors, and so on. And in this figure, you can see the kind of chain of events from determinants of health to inequalities in health status, how that translates into need and demand for care, consumption of care, and then hopefully an improved health outcome. Now, this is modified by access to care and these other factors. And we know that health literacy, if you're more health literate, you might understand a signal from the body as a need for care. But then when you also get to healthcare and should present your problem, this again has to do with health literacy, but also with language and other competencies that you might require. Now, finally, if you look at, Göran said that you need more resources to primary care, which I think is definitely true. But I think also you need to think of how to allocate resources between clinics. And depending on the reimbursement system, you might have systems. We had the initial system in Region Stockholm was very much based on the patient's demand for care. And then you have initially the location of a provider that will generate more visits, and high educated people tend to do more visits to seek care more than, that was the case we saw in Stockholm in the early days of the reform, that the increase in the number of visits happened more among those who were less sick, more healthy, and more high educated. And this will result in that you benefit clinics who are located in areas where you have a lot of consumption of care. Now, we had another problem with the reform. I said initially that you don't have this responsibility for population-oriented health promotion and prevention, and that has serious impacts for population health. And I'll show you just an example we had in that scoping review paper, how different reimbursement systems may play out. So we have here two populations of the same size. They are both, let's say, 10,000 people. And if you have resources provided in accordance to need, you will benefit disadvantaged areas, and the better off areas will get less. This was a situation we had in Stockholm before the reform. Now, when we had the choice reform came and we changed the system, it was said that everyone should have the same reimbursement. Now, what happens is that resources are increased in relation to the need in better off areas, and they're reduced in relation to need in disadvantaged areas. Now, if you add on to that this way that the differences in which we seek care, demand care, you will see that in better off areas, you will generate even more resources. And in some of these disadvantaged areas, you couldn't produce as many visits as you would be able to do in that area. So you would disadvantage that area even more. Now, we had a situation in Stockholm where this was the clinics, it was a very differential reimbursement. Now, what happened overnight was that all the clinics got the same reimbursement. And of course, that's not very sensible when you think of the differences in need. Now, the choice, the scoping review we did, we looked at the impact of the choice reform itself, but also on reimbursement systems based on fee for service in terms of what it did to access, to structure, process, and outcomes. And just to, you can read more about it in the paper, but we did this type of exercise to see how did it impact health among those with complex needs. Was made more difficult because coordination and integration of care was more difficult, and the reimbursement system counteracted holistic care, which could have an negative impact on those with greater needs, and so on. So in conclusion, I think the primary healthcare choice reform, it did part of its intentions in increasing access to primary care and increasing the average number of visits, but it did so particularly among those with lesser healthcare needs. It made integrated care for those with complex needs more difficult, and resource allocation has become less based on need of care. So in conclusion, the reform may have damaged equity of primary healthcare provision, contrary to the tenets of the Swedish Health and Medical Services Act. And this is something we think needs to be carefully monitored. Thank you.
Thank you very much, Bo, for a very comprehensive and very enlightening presentation. And I don't see any questions from the chat. Do you have any question before the break, Margareta?
I can wait so that we can have all discussions. Thank you again, Bo. This was fantastic, and it was so clear. So if we have this as a base for the panel, I think that is perfect.
Thank you.
Thank you so much.
Yeah, thank you. And we will have lots of time to debate this issue more in the panel. So now we will take a 5-minute break to rise up and stretch our arms and legs. And then we will return to hear from our Finnish neighbor. And we will meet again at 16:17. See you then.
Perfect. Hello, Sirke. Maybe you can put on your slide.
Okay, thank you, Margareta. Let's try if it comes.
Yeah. And in the meantime, when you are doing this technique, I am so very, very happy to welcome a colleague from Finland, especially you with your position. And one reason is that we tend to be a bit jealous of Finland because you tend to do everything right. In schools, you do better than we. And when it comes to COVID-19, you do much better than we. So now we want to learn from you how to do on the freedom of choice to have equity in health. I understand that Sirka Pikku-Jämse are a senior ministerial advisor at the Medical Affairs at the Ministry of Social Affairs and Health in Finland. So please let us know on the freedom of choice in Finnish healthcare systems.
So now I want to know if you can hear me and see the slides.
I hear you well and I see the slides, but you can put them in the full.
Okay. Now it doesn't work. Is it better now?
No, it's no difference.
Okay.
Visa bild, spel, well, doesn't say that. You can start speaking and trying it during the time.
Okay, but you can see something.
Yes, we see your picture.
Okay.
And it can be bigger if you start the bildspelet from the start.
Let's see. Since I seem to have two different preview, and now I just cannot find the way to put it any. It just, I'm so sorry, but I think this is the best I can do at the moment.
We keep that.
Okay, yes. Thank you very, very much for invitation and also of the previous presentations. I must say that it gave me the impression that maybe at this area, it's good that we haven't followed the big brother Sweden so keenly as we tried a few years ago, since you raised a lot of issues of the freedom of choice that we have to rethink also in Finland. I'm from the Ministry of Social Affairs and Health, and in that respect, I'm afraid that some of my themes or what I'm going to say to you is going to include also some aspects of the party politics, but hopefully also the population health policy we have now in Finland. I've sort of built up my presentation so that we'll go through what the status of the freedom of choice in Finnish healthcare system is now in our legislation, some experiences, what we have done in our, and as you notice, public Finnish healthcare system, what our present government is trying to do with our huge so-called SOTE reform, social and healthcare reform, and then what we tried during the previous government's reform for increasing freedom of choice in Finnish social and healthcare system. Why did it not proceed? So these kind of topics briefly. And here is actually what we have in our hälso- och sjukvårdslagen and of the freedom of choice for the patient. It concerns only actually the public or publicly financed health centers of the primary health care. You can choose once a year where do you want to be treated. And then actually you can also wish for a certain doctor or a dentist, but it is only possible if the health system can organize it. But then in Finland we have a few different types of freedom of choices we need to consider as well. Our system with occupational healthcare for those who are not unemployed and are working is a bit different than in many other countries, since it includes very largely the primary healthcare services as well. So those who are working have this occupational healthcare connected primary healthcare as well as the public one. And also students have two possibilities to choose: their student healthcare and then the primary healthcare. Also, the service vouchers are an optional. There is a special legislation to use of them, but in healthcare it is very few municipalities who use them. It's more used in the social services. So mainly our nowadays present system of the freedom of choice concerns only choice between public health centers and public hospitals. I'll go through that. So actually during the recent years, there is very little research done under our freedom of choice. We know that it's below 10% of the citizens who make an active choice per year if they don't move to another city and so on. And the reasons why they want to change the health center is mainly accessibility. It's near home or work, or good public transportation gets there. There may be short waiting times, good service, good quality, or bad service from the previous health center. But since the amount of the citizens making an active choice is so little, I think that it may be for the same reason as was discussed in the previous presentations today, that maybe the freedom of choice isn't actually so important for the patients. They sort of don't think that by having the freedom of making an active choice, accessibility or quality would improve. Maybe that's one point to think. And then we have the exactly same problem in Finland, that our country is geographically rather large, and we have areas where very scarcely populated, where for instance private providers are not interested to act, and also the public ones are forced to think whether it's any use to keep on services everywhere in Finland. So definitely geographically the theoretical freedom of choice is not equal for all citizens. Then one thing where we are not so good as you are in Sweden is that actually the information that is available for the patient to make a choice is very limited. Access and waiting times must be published in our public healthcare system, but then the quality or patient experience data it depends whether the providers publish it or not. It's optional. And then we don't have national quality registers. They are developing, but we don't have, as you do, Swede Spine or Swede Heart and so on. Finn Heart, Finn Spine are developing, but not yet so developed that our patients nationwide would or could count on the information from them. It's not openly accessible. So what is now planned in Finland in our health and social services? Our government is, should I say, for over 12 years, government by government has tried to renew the Finnish health and social service system. The background has been the same. We know that inequalities in health and well-being are getting stronger and stronger. The COVID epidemic has made it even worse. And our accessibility, especially to the primary care, is poor. EU has pointed to Finland that you should do something about it, and so the aging population needs more labor, where we have this shortage in Finland, and of course we definitely need to curb down the growth of our costs. So our present government has on December 2020 given a new reform legislation to the parliament, and actually this spring our parliament is proceeding through the legislation, and we are waiting that maybe during this summer finally we would get the laws ready for our reform to this administrative reform finally to come reality. The thing or the timeline is so that in the beginning of 2023 we would have our new system, which I'm going to tell you again. But this government has not emphasized freedom of choice, but has put a lot of resources for renewing our services, and especially at the primary care and basic social care level. So there are many projects funded by the government for the areas to renew the public health and social system. Our reform is so that we would have these larger counties, autonomous regions, somewhat the same system like you are in Sweden, because now we have been based on the over 300 different municipalities, and so the system is not, we cannot proceed that way anymore. The small municipalities do not have enough money, and so this government, present government's choice has been to strongly emphasize the role of the public sector, and especially the basic and primary services. I'll maybe, since we are in the lack of time, go through these slides rather quickly, but the strong emphasis on the public primary care system is hoped to be able to make shorter waiting times and better qualities for our population. We strongly believe into integration of both the social and healthcare services in the administrative level and also in the processes, so that the risk of fragmentation of both care and the social services wouldn't come true, and the whole thing is that this integration gives better service for the people. But then I'll go along for the thing that we didn't do. What was the previous government's plan, actually to do very much the same system that you now have in Sweden concerning the primary care. So to increase the freedom of choice very strongly and make this kind of same system that money follows the citizen's choice, both in the primary care and then sort of this capitation need weighted reimbursement from the state or county to the providers. And now comes this party politics part. Of course, this previous government was very right wing, or the parties were from the right wing, and the present government strongly basing of the public sector is a left and center winged government. But then this freedom of choice Swedish-like system did not proceed, even though we had sort of very much elements and very much data from your country. It was found that finally that it may not be consistent with the Grundlag of Finland. Very much discussion was made so that the public powers responsibility in all situations to be ensuring healthcare system might be lost if we would sort of provide possibilities so freely to private producers. So this kind of system that we need more control from the organization and that the organizer must have enough own service production are the lines that now are sort of examined in the parliament. Vice versa, how much is enough so that it's not it doesn't make too sort of unflexible system. So we laughed a bit that last time we were going to give too much power and too much services out of the public system, and now the problem is with this legislation which is now under the parliament's examination, that we want to keep too much in the public sector, so that it's not good that way either. So I think that I'll close so that in Finland we actually are coping with these two last points, that we really need and believe in the integration of social and healthcare services, and for political reasons now we want to do it inside the public system and use private sector only in certain portion and certain services. But we almost got the same system you have in Sweden. Thank you. I'm sorry of this mess, but last week we had a governmental crisis and we didn't know what's our direction, but now we believe that maybe this reform will proceed. Thank you.
Thank you so much, Sirko, for this presentation. Is there any question out there specifically for Sirko? Because if not,
yes, Margareta, I think I see a hand.
Lönnroth has raised his hand.
Thank you. I see your hand.
I think you guys have to do something to allow him to speak.
Okay, I will see if I can unmute.
Or invite to speak or something, because it's in webinar mode, so it's a bit different. It's not the usual.
Or maybe
perhaps you can write your question, Knut, to begin with, and I'll see if I can allow you. Oh, no. Let's see.
Kan vår kollega på Svenska Sällskapet hjälpa oss? Eller så här, kan någon av er hjälpa oss?
I'm almost, there we go.
Okay.
Now I'm allowing you to speak.
Good.
Excellent, thank you. But you cannot see me, but that's okay. So thank you, Sirko. I'm professor of social medicine at Karolinska, but I need to disclose that I'm also part-time chief medical officer on Åland, Ahvenanma. My question is not about that. I want to put the question from a Swedish relevant perspective. And I'm a bit curious if you have, or maybe anyone else have ideas about the difference in the position of occupational health, which you touched upon, which is much stronger in Finland and certainly on Åland. And there, it's not actually a choice for the patient, it's the employer. At least if it's the same in the rest of Finland as on Åland, the employer through bidding, actually here it is two private providers of occupational health. So the employer chooses and the patient or the employee just follows. And it offers much more than normally is done under occupational health in Sweden. So for example, if you need a certificate for a short-term sick leave, that's where you go. And I'm just wondering if that is putting a basis for less need for or desire for choice in the population, although it may not be that high in Sweden, as Bo was talking about. But is there something on the structural level where the strength of the occupational health system may make a difference in the need for, or the appetite for, choice reform?
Please, Sirko, open your camera and your mic, and please all panelists open your camera so we can see you.
Thank you, Knut. A very good question. And I think that may be one reason why the topic of the general freedom of choice is not so, well, we don't raise it that much in Finland, since people are mainly very satisfied with the occupational health care, including this primary care, diabetes follow-ups and whatever. So they don't need this freedom of choice in the public health centers, even though it's provided by the employer and so on. But in respect of the equity, then it may be so that those who are working and have this occupational health care possibility are also those who make the decisions, and those who are unemployed and with multiple problems, they sort of don't find the voice to emphasize this need for freedom of choice. You are right. This occupational health care is sort of a thing that mixes up things here in Finland.
We had a second question from the second hand raised was from whom?
Helena Zetterud, and I think the same procedure needs to be done there, that Helena allows her to speak.
Oh, Helene, you are unmuted. Or you need to unmute also, but I have allowed you to speak, so please.
I'm sorry. Thank you all for a very good presentations, but this was a mistake. So I must have come across some thing on my computer. So I didn't have any question, but thank you.
Okay, well.
Thank you. Technique is wonderful. With this, I would want that everybody, all presenters, open their pictures and that we start a panel discussion and maybe go back to, so that you comment on one another. Who wants to start? Is Göran the one to start? Who started first? You're free.
You mean, yes. I think it was very interesting that we had some presentations as my own. This was some primary vårdval in primary healthcare. But then we had this presentation on spine surgery. This is on specialized vårdval. And I think there are some major differences between that, because from the County Council point of view, you could really have control of the costs in the primary healthcare system, especially if you reimburse according to capitation. But in the specialized care, you have the problem of volume, as was very well demonstrated. And I think you should realize that, for example, in Stockholm, they have more than 40 vårdval in different, in specialized care. And I think my impression is that, for example, that the spine surgery, which is a rather narrow area, which could be more like locked in, and you could have incentive reimbursement. But then you have other vårdval, which is as a whole speciality, like ophthalmology or dermatology. And there the cost has increased tremendously for the County Council. And that might be a problem from the point of view of equity, actually, where you put your money in the system, especially as we know that specialized care is more in favor of those with good economy, good, for example, and primary healthcare more favors those with lower resources and low education, like low income and low education, for example.
Who wants to go on? I feel that, Bo, you never had any question after your speech. Actually, you did have a very good model. Maybe if you put on your empty model and as a base for discussion, because that included both the care choice and the reimbursement system, if you want. Otherwise, you just speak free. And unmute. While he's unmuting, Teresa,
yes.
Please start.
Well, Teresa can go first.
Okay, can I go first? I feel a bit rude now, but I can just quickly comment on Göran's comments or everyone's presentations, because I think, yes, we have to recognize the differences between specialist care and primary care, but I also think that, which was also that we found that with this new reimbursement and vårdval for specialty care, it was so important for them to start to collaborate more with primary care to make sure that the patients came to the right level of care sooner, so they can make sure that they could, to make sure that the right patients reached the specialist care. So I think that, and I think all of the speakers talked about the importance of information. And I think that it is a pity that we can't make better use of we have so much information, but we can't use it properly. And I think that is very important to decrease the fragmentation of healthcare in Sweden. So I just wanted to say that briefly, and I leave the word to you, Bo.
Thank you. No, but I reflected also when hearing your presentation that perhaps this care model and the reimbursement that went with it better suits the type of care that you were describing. You know, a care episode with a long defined follow-up. Primary care is not at all like that. I mean, if you were to do anything similar, you would reimburse by, for instance, health improvement or something like that. But I think it's much more difficult to distinguish what type of outcome measure should you have in primary care. What is the objective? How do you measure quality in primary care? Is it that patients are satisfied or happy? Is it that we deal with the right patients who have perhaps the greatest needs? Or is it the level of health improvement? You know, I think one issue though is that as soon as you introduce economic incentives, you might risk going wrong, so that the doctors don't really do what they're trained to do. They become businessmen instead. And that, I think, what we really need to get out of. And rather than having competition, I think we should strive for collaboration. And I think I'm also involved with some Finnish comparisons in other research projects. And I believe the setup you have in Finland with social care and healthcare being under the same hat, so to speak, and with much greater opportunities for integration, I think that's really the way to go. And in terms of the Swedish Choice reform, I mean, one issue with the primary care reform was that it meant to achieve innovations. But as the National Audit Office commented, there hasn't been hardly any innovation. I mean, you could think of some of these big corporations that provide both primary care and provide elder care. They could join up, because if we look at the challenges we have in Sweden today, it's an aging population. We have a fragmented system where, you know, you really need to know your way to get there. If these corporations could provide a package of health and social care, I think that might be something to compete with. I mean, if an innovation where you could actually bring the issue further. But it was interesting, but because I think the specialist care choice, I have the same reflections as Göran, but you know, the need of dermatology care is infinite. It just shoots up. So where do you draw the line? I think the system we've had now is more, it has been based more on need and a kind of gatekeeper system that, for instance, patients with skin cancer should see a specialist, but not if I just want to look at my spots on my body, which are not dangerous. It might be a different issue. No, sorry for rambling on. Margareta, you take back the word.
No, I love what you say. Sirka, you also need to comment, and then we have a question in the chat. Mm-hmm.
Oh yes, I actually now want to ask you something. That do you have or your population? Are you giving them enough data to base their choices on? Because in Finland we definitely do not. So maybe that's one thing why people sort of don't even want the freedom of choice, since they don't know why to choose. They only have the access times. So actually my question is about the use of quality registers, for instance. That are they used also by the patients, or only do they serve as a benchmarking between units and professionals and so on? Do you have any data on this kind of thing in Sweden?
Could I?
Göran has a comment. Maybe this is a response.
Yes. In our investigation, we found that the patients had mostly information was about accessibility and so on. And there was very, very, very limited information due to quality. Of course, accessibility might also be a matter of quality. But for example, our quality registers for the first regarding primary healthcare, we had not very much data in quality registered. It's improving, but if we had, we didn't have them available for the population. And one reason for that, it's also, I think it's very difficult to serve that kind of data related to, for example, different primary healthcare providers, because these differences, they might be related to the patient mix, for example, and that's very difficult. And also the number of patients is very limited if you should compare between primary healthcare providers. It's not enough usually to get the statistical significance, for example. But the short answer is no, we are not serving the population with very much data so that they could make the choice from data of the outcome of care.
Just to put in, because this is an important program, but I just wanted to give time for two questions which I can combine. Sofia Dahlin says that 1000 is a system in Sweden, and Bosse, is 1000 an example for that kind of collaboration which you suggested? Can you tell people what is 1000?
Yes, 1000 is, what happened? 1000 is the municipality of Norrtälje within Stockholm region. They have joined forces, the region and the municipality, creating a common company which provides the healthcare and social services. And that has been in place since 2006. It seems, well, everyone is happy with it. We are actually looking at it from a research study perspective, looking at how it affects unplanned healthcare utilization, and also trying to look at if it affects mortality and things like that for older adults. And everyone is happy about it. We've also had interviews with staff and with some patients, some users. However, it doesn't seem to, to be honest, it doesn't show a big difference in terms of healthcare utilization. One interesting issue though, when we've also looked at or I've had an assignment in the country council to look at COVID-19, and it seems that Norrtälje municipality has been less affected. The older people in Norrtälje have been less, there have been less deaths in Norrtälje in terms of both population rates and so on compared to others. We don't know if it's just because it's a small municipality or if it's just the stage when they were hit by the pandemic. But it does seem to have some advantages. But again, it's a bit difficult to evaluate scientifically to really see an impact of this, but it's promising.
We do have one more question, which goes back actually to many of your presentations. It's Jerker Hansson who says, which forces has driven the change? Is it that doctors wish to be independent and earn money, and that politicians want to get votes from strong groups which are not so sick, risk capitalists, or what are the counter forces? Because I think it's very central. And Joanna, we talked about the forces of professional pride and learning systems, and of not putting money in the reimbursement so that you get extra money if you go extra steps, but you have some money dependent on the need, and then your reward is professional pride. Who wants to comment? What are the forces which we shall drive on? Who wants to start? Göran,
I think regarding the vårdval, it was politically driven, and I think it was said wish to get in more of a competition between providers. It was also a wish to get in more from the majority at that time, to get in more private providers within the system. And there was also a belief, as I said, that these solutions should solve some problems. For example, regarding accessibility and so on. And my message was that it did to very limited extent. I also think that because it was very much focused on effectivity and so on at that time, and they really thought that if you fix this, we will like more care out of the system. But that's not the same as you get a more effective system, actually, because you must also, as Bo said, for example, in the Stockholm primary healthcare, you created a lot of unnecessary care with the system.
We are having to close soon. I want to give you 45 seconds for a concluding remark. And what do you think of this? I shall give information from Eva Arvidsson, who works with primary care quality. We do have a national system for primary care, primärvårdskvalitet, with clinical measures, which has been developed very, very much. And 85% of all health centers have access to this data, and all patients can access some of it in Vården i siffror. So we do have possibilities. With this and with all wise comments, shall we go back and ask, you may raise your hand, and who wants to start? What is the take-home message? What do you want to say to people? Who wants to start? Sirko.
Okay. What I take home or tell everyone in Finland is that maybe it was a little bit disappointing to hear that no new innovations at large extent have been found in Sweden, and the logic where maybe the private providers act in private healthcare was not so easily taken to the need of the whole population, and working in a different capitation reimbursement and so on. This holistic way of giving care wasn't so easy that new innovations and better access would have been achieved. Maybe that's what I...
And briefly, the three of you, who wants to say something, a final comment from?
I also wanted to urge you to maybe comment on whether you think that the free care choice reform is compatible with health equity.
Yes, thank you.
I would say no. I think the free care choice reform actually opened up for a consumer way of regarding healthcare. Actually, there's a dissertation from the Department of Sociology of Law at Lund University, which is looking at those aspects of digital care. And he makes the case, Peter Bergvall, that this choice reform opened up for this way of regarding care. He says from a survey that now the digital health and as well as the choice reforms, they are very parallel to internet shopping. You know, you use that service because it's convenient, and then you forget about the rest. You don't want to get involved. You don't want to think about issues to do with justice or distribution. So it's really paved the way for a shift in the way we regard healthcare.
Thank you. And Therese?
I can just say briefly that I guess it's a question whether we want private healthcare providers or not, and if we want them, under what circumstances can they provide care, and that professional pride is the most important, but you should not underestimate the power of financial incentives. That I think I want to say.
Thank you very much. And Göran, last comment.
I think we should conclude that free care choice within specialized care and within primary health is two completely different things, actually. My message is that is it compatible with equity? I think if you design the system that promotes actually, which is actually possible, it improves effectivity within the whole system. You might, and some county councils do better than others on this side, that have designed the reimbursement system in a way that promotes equity more than others do. So it's possible to get actually within primary healthcare, but we still have the challenge to design a system that promotes innovation and collaboration. Because how do we reimburse collaborations, for example? That's extremely difficult. And the challenge in healthcare today is to get to think of the whole system where you really need collaboration between providers.
Thank you very much for the panel, and thank you very much to all participants. I will paraphrase the book Quality by Design to say equity and innovation by design. I guess that's the next step that we have to promote. Thank you everyone for your participation, and those of you who want to participate in the årsmöte for our Förening. This is very well. This is very well. This is the Swedish and English. I put the link into the chat, so those of you who have difficulties finding the invitation can go there, and we'll start at 5:15 in another Zoom meeting. So thank you very much, panel. Thank you, everyone, and have a nice evening wherever you are.
Thank you.
Thank you.
Thank you.
Bye.